Hello, this is Elena Coucher once again, and I am presenting to you Module 3 of the Preceptor Development Program. These are your Module 3 outcomes. These are listed in your, provided to you rather, in a handout in your Preceptor Development Notebook. I think we can all agree that communication is an essential component to healthcare delivery. As you all probably agree and know, it is a very vital part of the delivery of care for the patient. Communicating with other staff, handing off the patients to oncoming nurses, physicians, respiratory therapists, the patient, communicating with family members. As preceptors, we have to be able to guide that preceptee in communicating effectively with all who are involved with the patient care. That's why SBAR is a very powerful tool to instruct on the use for the preceptee. SIOCO delivers some powerful numbers quantifying the dangers of poor communication. With the Agency for Healthcare Research and Quality Improvement, it was a 2004 research study that said 70 to 80% of medical errors are related to problems with poor communication. So what is Joint Commission? And we have to worry about what Joint Commission has to say about that. That accrediting body, they provide an estimate of greater than 60% of sentinel events occur because we have poor communication. So this is why, as a preceptor, we have to guide our preceptees to correctly communicate and effectively communicate. Do you ever remember needing to call a physician for the first time? I can think about some of my times. Making sure as a preceptor you teach the correct communication process is it's a vital component and a vital task that we have to really lead and guide the preceptee on. I think most of us at this point in time throughout our healthcare career know what SBAR is. We know what it stands for. We know why it's so important. Communication is so important that we can find many resources and forms for SBAR on the Institute of Healthcare Improvement website. And I do encourage all preceptors, I encourage any nurse actually, to familiarize yourself with the IHI. You might even begin introducing your preceptees to it. When I read through the SBAR process, in my mind, it's just another tool to help the preceptee to critically think through a situation and to communicate all the necessary information effectively. It took me back to one of the first times I called a physician. No one led me through the process. I pretty much flew by the seat of my pants. You want to provide your preceptee with way more than what I had. You want to maybe get them a form, have them write down components that they will need when they call the physician. This way nothing is forgotten. Have them open the patient's chart and epic. If there is something the physician asks for what they have that they may not have jotted down, then they have it open. It's right there for them. There's nothing worse than feeling even more inadequate than you already do when you can't remember something because a physician is shouting at you. With situation, you think about what is happening at the present time. You want your preceptee to start with identifying who they are, identify the patient and the reason for the communication, and then verbalization of what has been assessed and prompted the communication. With background, what were the circumstances leading up to the situation? Instruct your preceptee to give a brief history of the current symptoms. Include all systems, lab work, medications, anything pertinent for the reason for the communication for the patient problem. In assessment, what is your basic assessment of the patient? The nurse should state what the problem may or may not be. The patient has had 180 mils out of their JP drain. I've not assessed any signs of hematoma. The drainage is serosanguinous, but according to your standing orders, a phone call was warranted. You know, really put it in perspective what I'm calling about. Give them everything that they have. Sometimes I think that when we're thinking about communicating with our physicians, most of us know what our physicians want. We know how to communicate to them, and I think there's an expectation. Maybe it's not an expectation, but we sometimes forget that the preceptee has no idea. but we want to lead them through. We want to have them go all the way through the SBAR so that they can communicate effectively. What about recommendation? What are your recommendations to the MD or other healthcare professional? This is something for them to think about. Obviously, I talked about, you know, the patient with the JP drain. That was an actual conversation that I had with a physician. Um, so uh, I'll tell you a little bit about that later. It's quite funny now that I can think of it now, but back then I was not laughing too much about this. But we probably have these situations that occur more often than not where you have a physician who is rather annoyed by the fact that you've called and do not want to be bothered. So you want to make sure that your preceptee has everything down. And that's why I would like for you to try to use SBAR. You might already do so and not realize that you are. But maybe just for them, you write SBAR down. What's the situation? Let's write it down. What is going on? What is the background on this patient? What's the assessment and the reason why we're calling our doctor? And what do we want to recommend? That way they have it right there. It's all in front of them. Phone skills. As the previous slide stated, it's very difficult to call the physician for the first, second, third, fourth, and many times um, until there's a level of comfort that's reached, until you get to kind of know who those physicians are. Now, what can you do? Sayako lists several key ways to help your preceptee with this essential task. Practice with them before they call. If it's applicable and you can, please practice with them. Write down what needs to be said. Let them listen to you or others as a way of learning. Remind them to provide information using the SBAR because the on-call may not be familiar with that patient. Assure them that knowing when or under what circumstances to call definitely comes with experience. Some additional teaching for your preceptee that you might want to guide them on would be calling for another nurse or dealing with rude physicians. Calling for another person is not necessarily prohibited. I mean, it happens, but you want to guide the preceptee in knowing when it is okay and what to do. He or she should thoroughly investigate. Let's figure out what's going on with the situation. Get a little bit of a mini report and be sure all of information is obtained so that it may be conveyed to the physician that they're calling for that particular nurse. And rude doctors, man, they are out there, aren't they? For whatever reason, they rear their ugly head from time to time, but we need to always prompt our preceptee to remain professional and not become defensive. And defense is a natural reaction. We don't want to have them to be rude back. We need them to stay calm and be polite, then follow through with the entire SBAR process of communication. I mean, what are they going to say when you're providing them with everything necessary? I actually had a physician. This is what was so funny. I actually had a physician once who was very rude and asked me why in the world that I was calling him. Well, sir, your standing orders state, and so I said what the standing orders stated, which I should have called according to the standing orders. The patient did have quite a bit out in their JP drain. However, and it was a breast surgery patient, and I did not feel like that there was anything going on, but you cover your butt, and so there was a little bit of covering going on there because this particular physician could be a little bit on the testy side. So when I did so, he said I needed to think twice before following a standing order, which was his. And so I did get defensive in return. I did try to remain very, very polite at first, and occasionally it calls for it, but we certainly don't want to model that for our preceptees. Maybe down the line as they get a little bit more comfortable, they might could come back with something that sounds professional versus what I can remember. See, I'm learning from my situation. What I did was, when he said, do you want me to, I needed to think twice before I followed a standing order. And I asked him, did he want me to write that as an order? Which he did, and so I did. Um, that was, of course, I can look back on that and I know that that was inappropriate. But right then and there, I didn't think so. So stacking, what is it? Stacking is about the decision-making work that RNs do on a daily basis. The what, the how, the when, the where, what, anything going on for care of the patient. Stacking is also a way of you anticipating the care to be given. It's an idea that's out there now, evidence-based research on stacking, which has the nurse getting all of her or his things together, all their ducks in a row, and choosing, basically, I've got a set of patients here, and instead of me just going down the line and choosing which patient that I'm going to go see first just based upon the room number, I'm actually choosing which patient that I'm going to go see first based upon the acuity of what is going on with this patient, and then stacking that care, knowing that I am going to get everything done on this patient that I can possibly get done while I'm in the room, and prioritizing all of my care while I'm there, and then working my way down the line. And I think about it as when I used to drive into the hospital every morning or every night, when I worked on the floor, and I would think about the type of patients that I knew might be on the schedule for the day or for the night that I was coming into, and I remember mentally planning what I was going to do to take care of my patients so that I could get everything done that needed to be done on them and be able to take care of the little things. And that's kind of what stacking does. But how does that pertain to you as a preceptor? Well, it's a skill we practice, and we don't realize that it's happening. Um, so you don't want to teach your preceptees to trade off, unless it's very important to trade off some of those decisions. We have to be mindful and create positive outcomes versus unsuccessful patient outcomes. It is a very cognitive function. The success of our ability to stack will determine the successful or unsuccessful accomplishment of our daily task. And it does have a direct relationship with quality of care, safe patient outcomes, and the work environment. What I found interesting, that Isioko found through, and this was done through eBright, through their research, is that nurses tend to make those trade-offs, and many times we're making decisions in the clinical setting and making these trade-offs, so things are missed if we're not mindful of that, and we end up with unsuccessful patient outcomes. Teaching mindfulness and trade-offs should never compromise the patient. You have to teach the preceptee to organize their care. Um, let's base who we're going to go see first over who is the most critical and what is going on with them. And let's go in there and let's stack our care. Let's kind of bunch it all up. Let's whatever we can do while we're in the room to do and make sure that our patient is safe and taken care of and everything is looking good for them before we move on to our next set of patients. Which leads us right on into prioritization. As a preceptor, we are the role models for our preceptee, whether these are students, new graduate nurses, or seasoned nurses hired from another facility into our facility that we're working in. Nothing should be taken for granted, though, when providing valuable preceptorship to them. As preceptors, I think we need to hone prioritization and critical thinking skills. I've already touched on critical thinking, and I'm touching on it all along the way. This is done by asking questions. Ask questions. Don't tell. Don't delegate. Don't say, go give this medicine or go and do this assessment. Tell me when you went to do this assessment, what did you hear? What did you see? What did you feel? Why are we giving this medication? So ask those questions. Ask all of those deep, detailed questions. We got to hone their prioritization and critical thinking. It's vitally important. Um, we want to provide feedback. We want to lead them towards the safest path of patient care. Remember the 5-minute preceptor from Module 1? Again, it's really about prioritization. It is a critical thinking exercise to lead them through those questions. What are we going to do first? Which task is more important to complete first? Provide me with that rationale. Why are you choosing to do this before we do that? Critical thinking, stacking, and prioritization all go hand in hand. It is modeled, it is honed, it is practiced, and it is encouraged. Prioritization can still be taught and learned even after care has been given. So if a preceptee has gone in and has given the care, we can talk about why did you do it this way? What was the reason you did not intervene, or why did you choose this intervention over the higher need one? So really think about that as you are leading your preceptees through their educational process, so that you really can help them to think deeper and more clinically about their patients. But how can you do it? How can you teach it? It's kind of a difficult task. I'll tell you, we get paperwork. We have to, some of you probably have been my student at one time or another, or you've had my students and you've seen their paperwork. We have them to write out their nursing problems, and they have to prioritize those nursing problems. Which one is number 1, 2, 3, 4, 5, 6, 7, and 8? Um, Throughout the preceptorship, start the morning after report with list building exercises. So make a list of the patients. Okay, let's do things a little bit differently. Here's our list. Let's create a nursing diagnosis for each one. List tasks associated with each patient, including interventions from the nursing diagnoses. And from that list of tasks, have the preceptee to assign either a high priority, second level priority, or third level priority to the task. Y'all, this seems like, oh, that just seems so time consuming, or maybe it seems so juvenile to you. But in reality, you're teaching your preceptee how to prioritize, and you are teaching them how to critically think about their patients and what is going on with them. It is a good task to do in the morning with the patients that they're taking care of. I really think that it would help gear them towards taking care of their patients in a better clinical manner. Feedback. Oh, we've talked about feedback quite a bit. I don't think anybody likes to do it. I don't know anybody who really likes feedback. I honestly don't like to give feedback to students, but it's a necessary part. I have to do it. I love to give positive feedback. What I don't like to do is give negative feedback. Let me give you an honest negative feedback situation from my time as a new graduate nurse. My preceptor from the beginning on the critical care unit was not the most welcoming, and that is putting it very, very nicely. Her feedback to me was always filled with snarky comments, and it created a very hostile relationship that eventually I just had to leave. I couldn't stay there any longer. It was total abuse by her. There was actually a time I thought I had chosen the wrong profession. Um, so be careful of your feedback with the preceptee. You are in a powerful role, so use it wisely. On another note, as a former preceptor in a clinical setting and now one who must provide feedback to students, I do find the process of providing feedback when it needs to be constructive and it's not the most positive. I find it to be very stressful. Swihart and Figueroa describe this anxiety that you feel with it, that anxiety-filled task, and cautions us to provide feedback in a very professional and compassionate manner. I think sometimes when we're looking at patient care and we're looking at the safety of the patient, there's like a knee-jerk reaction that we want to take when we want to give some feedback to our preceptees or even students. We don't need to utilize the knee-jerk reaction. We need to make sure that we're given constructive, and it needs to be delivered with compassion and kindness. So types of feedback: there's negative, there's positive, there's constructive or performance feedback, and then there's some do's and don'ts with it. Constructive feedback or performance needs to be given in situations which require the preceptee to learn from a situation, such as when an error has been made or it keeps being repeated. It has been asked for, the patient is at risk, if specific guidance is needed, then as a follow-up to that guidance. If the preceptee is not meeting expectations or shows poor performance. This is why writing those objectives that I've talked about is so important for you guys. In addition, don't give performance feedback via email or text message. That's just, you don't need to do that. If you're an educator, give your feedback should be given in a way that promotes growth of the preceptee. Don't say things like, next time don't, you shouldn't. Instead, be a 5-minute preceptor, encourage them to critically think about how things could have been completed differently. But do be an active listener. Do not encourage or participate in a gripe session. Do watch your body language. Maintain eye contact. Do not fold your arms in front of you. Folding your arms in front of you is just, is mean I'm shut off from what we're talking about. I'm shut off from you. Don't provide feedback when you're angry. Do provide the performance feedback in a sincere manner. Your attitude and words should convey this. Don't offer performance feedback based upon hearsay of others. You need to make sure that you have your own assessment and you're seeing this with your own observation. But I do want you to give details and provide examples of the behavior in the feedback. Don't focus on the preceptee's personality. Personality feedback should be addressed if the preceptee continually does something like leaves for breaks without notifying you or other staff members. That would be a personality trait. But otherwise, you don't want to give feedback just because you don't like the way that they act. Beer. No, you aren't going to the bar. I loved it doing this. Sioko identifies these methods as a better way to deliver performance improvement feedback. BEER stands for behavior, effect, expectations, and results. With the behavior, you use clear, concise language, provide examples, and do not generalize anything. I'm disappointed that you do not follow the correct steps to ensure proper technique when suctioning the patient. For effect, the effect of the behavior may negatively affect patient care and safety. Are you aware that if you do not follow the proper procedure when suctioning a patient, the patient may experience a negative outcome? Expectations. Preceptees are often attuned to the fact that they require assistance to fix a behavior. You're the preceptor, their mentor, and when this comes, the positional power to provide the guidance necessary to correct things that are wrong, while at the same time you have to build their confidence up. Set the goals, work towards those goals, and be sure to provide the preceptee with examples of how you've noted them attempting to correct the behavior. Results. Express your confidence in their ability to improve. Offer your support. Continue to document all aspects of feedback, and because you must explain to them the ramifications for not correcting the behavior, especially when patient safety is at risk. Some tips for delivering feedback. Find a quiet place and ensure, though, that it is a professional setting. You know, finding that quiet place, reserving an area that you can go and you can speak to them and you can address the behaviors or address what is going on. Or even if it's just delivering some end of the week feedback. Put the preceptee at ease. Present specific examples of the negative or inappropriate behavior. If possible, provide them with the positive as well. I noted that you did this. However, I want to say that you were professional in this manner. Do something that's positive as well. Discuss the present and future needs and goals. Expound upon your confidence in the preceptee's ability to meet the objectives. Be genuine in the constructive and praise feedback. And ask what you can do as a preceptor to improve the orientation and competency process. Delegation. It seems like, again, such a juvenile thing for us to talk about in a preceptor development program, but we don't need to be a culture of delegation. If we're in a patient's room, we need to model delivering patient care to our patient and not going out to find someone who can do the task that we can do. But performed incorrectly may lead to decreased quality of care and unsafe patient conditions. Discuss hospital-specific policies with the preceptee concerning delegation. And do not allow your preceptor to be used as staff before orientation is over. What does it mean for the preceptee and preceptor? You have to teach it and you have to practice it. The preceptor should direct the preceptee in delegating delegation opportunities. You need to ensure that the preceptee effectively delegates and understands who and what they have the authority to delegate to. But you also want them to make sure that they're doing patient care. And okay, so the patient needs a pain pill. If it's something that y'all can walk out of that room and deliver that patient care, then you can deliver the patient care. You don't want them to delegate that to someone if it's something that y'all could do together. Review the 5 rights of delegation to the preceptee. And you're probably reading this slide and hearing it, and is she serious? Are we really going over delegation? I've been in nursing education for 10 years now, and I've been a nurse for 15. I do not deliver a lecture without first studying all the components, even if this means I'm getting a refresher over something I already know. The point is, with delegation, we all need refreshers to ensure that we have positive patient outcomes as the end product. I do know that many of us, for delegation, we feel like it's probably second nature to us. But for a preceptee, this is not a leadership component they have practiced yet. So they need to become proficient at it, and they even need to learn not to fall into a culture of delegation, but be able to deliver patient care to the patient without delegating little things. The 5 rights of delegation, I just discussed that a little bit. Right task and the right person. The right task, discuss with the preceptee what can or should be delegated. Instruct the preceptee to match the care to be completed to the right person. Communication, the right communication, circumstances, and supervision. Care may be delegated to another healthcare team member, but the preceptee must understand the RA is responsible for the supervision and monitoring. You may delegate it, but there needs to be a follow-up. So in supervision, you have to teach your preceptee not to just expect that it's going to be done, but they need to follow up and ensure that it was done. When you know what you know. Preceptors and even nursing faculty very quickly are able to recognize who has it and who doesn't. And usually we can see these preceptees struggling, or maybe we receive a word of caution from others that give us that blip on the radar. Whatever the case, the first initial response is to make close observations and become hypervigilant to the care of the patient. We can't just say they aren't ready, they are unsafe. They just are not getting it. They need more time. Have you addressed these concerns with the preceptee? Have you been writing weekly objectives or outcomes? If so, have you provided the preceptee with the feedback, whether positive or constructive? As leaders, we must have written documentation of failures we are witnessing in the preceptorship. The gut feelings or nurse SBAR may be valid in our minds, but it is not valid documentation of what we're seeing and hearing. In the upcoming slides, we're going to discuss success as there warning signs the preceptee is struggling and ways to intervene and document. So they're struggling. Initially, the beginning evaluation begins on the first day and is ongoing. Make sure expectations are clear and concise in nature and written. Those written expectations and goals need to be signed. Retain copies for yourself, preceptee, and administration. So you start identifying that there is the struggle going on. It's important as you move through these slides that you begin to practice these tips and remain objective. Document objectively, report objectively, and provide supporting documentation. Ultimately, patient safety is a preceptor's top priority. If you ask yourself the question, is this preceptee safe? And your answer is a resounding no, you have to have been documenting all along the way. And if you have, then there's justified validation, which would suggest this preceptee may not be successful on your unit. You need to see it early. The following are just warning signs a preceptor needs to note and document. Chronically late to the clinical setting, leaving without letting anyone know, hesitation when providing answers to critical thinking questions, frequently asking for help without first attempting to find the answer, sloppy in their work and documentation, unprofessional behavior, unprepared for their days, unsocial and exhibiting continual distancing behaviors, and easily distracted or not interested in learning. So then we need to understand. We're still talking about our road to success. To understand, we encounter these types of preceptees. It is imperative that as a preceptor, we remain sensitive and empathetic, which means you may need to complete a self-evaluation and ask yourself, if it were me, what would I be afraid of? How do you visualize what your role would be in a similar situation? Would you feel as if no one was available to assist you? Would you feel equipped to handle the situation? Would you recognize that there was a problem and what would be critical for you to focus on? Then we want to clarify. We want to meet privately, be kind and objective, focusing only on the behavior directly observed. It will not be easy. Remember, a few slides back, I discussed about preceptor anxiety. It's kind of one of those things you can't avoid when you're having to talk to a preceptor like a preceptee this way. Now attempt to gain some insight. Use some psych skills you learned as a student. Now tell me how you feel. Share with me why you feel this way. Tell me how you feel when working with the patients. Are you happy with your work here on this unit? Tell me where you were having difficulty. How would you rate your performance? You're also put accountability back onto the preceptee when you're dealing with one who is on their road to being unsuccessful. Then contract. Encourage the preceptee to take notes and document. You want them to document as much as you do. The contracting is quite an extensive section, but it's important that it is carried out for a turnaround of behavior, success, and patient safety. You want to build the contract between you and the preceptee for success. If the performance was severe enough to cause harm, then interventions may include extra coaching and assistance, emphasis on following protocols and guidelines, share conversation and documentation with administration. Extra coaching and assistance may mean regroup or start again. You may just have to start over. Let's go back a few weeks in our orientation. Find out where the disconnect began, or perhaps decreasing the amount of patients the preceptee has been caring for. Take over a skill for a preceptee to demonstrate it once again, and then closely monitor them as they repeat the skill. This is a type of remediation. The ultimate goal is for the preceptee to be successful and patient safety being maintained. On the previous slide, we discussed making the contract, and it should be objective and focus on the behaviors. You want to use positive wording. You want to use encouraging wording. You want to be clear, legible, and understandable. Exactly what was stated. If the preceptee has identified resources he or she needs to be successful and meet objectives, then you may need to assist the preceptee with ideas and suggestions. Also, other areas of orientation objectives need to be met and stated as much. Include a time frame as well for these contractual objectives that you are developing. When you evaluate, it's guided by the orientation manual. There should be a weekly preceptor-preceptee meetings. When the preceptee is evaluating the struggling, preceptor is evaluating the struggling preceptee, meeting times need to increase. The evaluation process may need to occur on a daily basis. Each evaluation session must be documented and detailed, and be sure the contract is being followed. Sign and date any and all updates to the contract. Then summarize and sign. Depending on whether you have contracted with the preceptee for the remainder of the orientation or for a specific time frame, a summary of that performance should be completed. You want it to include objective observations of the behaviors, the preceptee's perspective, if the preceptee has attained and the agreed upon goals of the contract, and was the behavior changed? Have they met an acceptable standard? Are they safe? Whether this is the end of the orientation process or the end of the struggle, you need to sign off. But what if? Hopefully all the steps the preceptor has taken towards success were rewarded with a preceptee who's moving forward. But what if they're not? What if all the objectives and goals have not been met? Remember that contract that the preceptor and preceptor drew up? You have to refer to it and identify those areas that they are still weak. If it is just one goal, does that make the preceptee a failure? No, absolutely not. You can still provide guidance in achieving the orientation or contractual goals. Again, you have to document, document, document. Maybe at this point in time, if they haven't met goals, you can suggest additional time to work with the preceptee. Again, you have to have documented appropriately during this time. Recommend the preceptee work with another preceptor. This may be more appropriate if you both have had trouble and you couldn't get on target with one another. If still unsuccessful, keep all the documentation for yourself and supply a copy to administration. We just have to document in order to know who is successful, who is not, the reasons for their success and the reasons not for their unsuccessfulness. My final thoughts: precepting can be rewarding, but it is not without challenges. It is important that preceptors be positive and patient, practice professionalism, be compassionate, seek to resolve any and all conflicts and negative behaviors, and keep an open mind, and also maintain excellent documentation. Now this module will lead you back to net learning for a 9-question competency exam. Thank you for listening.